Results of my exam.
All right, they're just in. So I did a knee exam on him. Completely negative. We found nothing. You were there.
Oh.
Just like, yeah.
Spoiler alert.
Spoiler alert. He was actually part of this.
Welcome back to another episode of Past Your Prime, the podcast for active adults balancing life, training, and rehab. I'm Alex Kiker, pro volleyball player, dad, and a guy whose knee now makes a sound like a crushed bag of chips every time I sit down. When you're an athlete over 35 and your knee flares up, it's an instant panic. You run out, get an MRI. The report reads like a horror movie. Degenerative meniscus tear. You immediately assume your jumping days are done and it's time to get a surgeon to go in there with a vacuum cleaner. But today, we're busting a massive medical myth. Your MRI report might just be the internal equivalent of a gray hair. Normal, expected, and not the reason you're hurting.
Gray hair?
Yeah, because it's normal. You know, you have a gray hair.
Oh, yes.
It's normal. Like, you're not dying. You just have a gray hair.
Your knee does sound like a bag of chips.
I don't know.
It does. It is
It was a fun metaphor to
It
say.
Oh, God.
I've got Craig Smith,
Yes.
my co-host, physical therapist, and strength coach with me here today, and we're breaking down some knee myths, MRI scares, normal knee pain, what's going on with your knees. I don't know exactly what we're talking about today, but we're going to talk about knees.
Well, partially, we're also going to dive into you have knee pain right now, or you did yesterday.
I did,
jumping.
2 days ago.
Go ahead and go into it.
No, I just took a weird landing, and I was like, oh, man, my knee kind of feels weird. And I thought about shutting it down, but I continued on for another hour without issue.
One landing was painful.
One.
And then you kept playing the rest of the time, no pain.
It probably pain for about 5 to 10 minutes after that small episode. And then I forgot about it.
This is where I always start to go down a route. So let's just say me and you are having this conversation in the clinic. I would understand that Alex uses different words to make sure that he doesn't say pain. Did you feel more tightness?
I've been very cautious about that in all facets of life.
Have you really?
Yeah.
Being clear on the words that you're not using.
I tried not to use the word pain anymore. Like, I had an uncomfortable feeling.
Yeah. That's awesome. But did you have quad tightness?
No, my other hamstring was tight, but not on that specific knee.
Did you feel an awareness of your knee?
Yes.
Was the knee stiff or swollen feeling?
No.
Did it become achy? Did it become more noisy? Was there other terms that you would use to describe it that weren't pain?
No, I had a quick shot of pain.
And then afterwards it became more stiff. That was basically the whole experience?
Kind of, yeah. I guess I did become more aware of it, like I said, for like 5 or 10 minutes, and then it was gone. I think I just had a bad landing, which is one of my problems overall anyway.
Well, you know what?
I'm a stiff lander.
You are a stiff lander, which we'll definitely dive into. Before the start of this episode, I did a full examination of his knee. We'll give the results of that and explain it.
Oh, gosh.
But you know what is interesting, that when you brought up this topic, I also recently had a phone call where somebody called in and they had just had imaging that said what you just said, where they had all sorts of issues in their meniscus, and the surgeon ended up doing a meniscectomy, which is just where they go in and they clip part of the meniscus out, the part that's part of whatever's causing the issue. And then from there, the person afterwards asked the surgeon if they needed rehab, and the surgeon was basically like, no, you don't need rehab, and you'll be good to go. Nothing really to concern yourself about. And it's just a brutally not accurate view of what should be done post meniscectomy, and I want to dive into that too.
Isn't there research that suggests that, generally speaking, meniscectomies don't have a better outcome than just rehab on its own?
Yeah, I mean, there's been variety of different ways that they've looked at it, from doing surgery to looking at even the validity of the surgery. One of the more interesting studies, and I think I've even shared this before, they had where they took a group of people who had meniscal or mechanical symptoms in their knee. They had an MRI that showed that they had a meniscal tear, and they randomized them into two groups. One group, they did the meniscectomy, where they went in, they cut out the piece of damaged tissue. The other group, they also created an incision, but they didn't actually do anything else. They just closed it back up, and there was no difference in outcomes between the two groups.
Wow.
And they've done that study multiple times now. It's a pretty robust finding. So that, I mean, just from that standpoint, I mean, it just kind of shows you that there is, the bigger the intervention, the bigger the potential placebo.
I feel like both those groups of people are pissed off, though.
Which one did I get?
Well, no, like, you cut me open for no reason. Like, I'm just angry that you cut me open. And, like, you cut me open and took out a piece of my meniscus. And the person that literally just got cut open had the same outcome, if not better.
Well, you know what they used to do with meniscus surgeries?
Not do them?
No, they used to cut the whole thing out.
Wow.
They used to do full meniscectomies. So they would go in and they just take out all the meniscus. And
then you can never walk again.
Well, yeah, you know why they quit doing it?
Well, I don't.
Well, if you think about how a knee, like the structure of a knee, so you have your femur, which is like two basically round structures sitting on a flat surface in the tibia. It's not that congruent, right? So it's not as if that flat tibia fits the circular aspect of the femur well. And so the meniscus, what the meniscus does is it basically increases the joint contact. So it basically takes and distributes all the force that's coming from the feet between the femur and tibia and disperses it across a wider area.
So what happened to the people that had it fully removed?
Well, you basically take all the contact area, instead of it being distributed across the entire knee, and you put it in a focal spot. So stress is literally the amount of force over the amount of area that it's contacting. So if you cut any portion of the meniscus, if you cut it out, you basically have a ball on a flat surface, which doesn't go well. It becomes arthritic. But even people with basic meniscectomies, you can have 200 to 300% increased joint compressive forces, which is dramatically worse. So the whole idea, just from a basic standpoint, if you get a meniscectomy and you don't get rehab, I don't understand the purpose of the meniscectomy, because you're basically driving yourself down the route of a total knee. So why not just go get a total knee if you don't want to take care of it? I mean, I think it's silly, because if you can't, so at that point, there's no improving those joint compressive forces. Like, that's going to happen.
Yeah, it's permanently damaged at this point.
It's permanently changed, right? So you're always going to have a force over area issue, and the only thing that's going to make it better is your ability to absorb force better. So be able to transfer force absorption to the muscles and be able to perform the movements in a way that basically distributes force through the whole system better.
Okay. Results of my exam.
All right, they're just in. Remember, there's a few ways that we can look through getting a diagnosis. You have the structural exam. So I did a knee exam on him. Completely negative. We found nothing. You were there.
Oh.
Just like, yeah.
Spoiler alert.
Spoiler. He was actually part of this. No swelling, full knee motion. Where before we've caught swelling before.
Yeah.
Right? No swelling. We did check some of the muscles that are absorbed that are used in the force absorption chain.
All weaker than at least my past exam.
Than I can even remember in a long time, which is fascinating. So he was unable to really produce that much force with his glute medius or his glute maximus, which, with how often you work him out, that's a little bit surprising, right?
Kind of. Yeah.
What does that make you think when that happens?
I've been sitting too long.
Could be sitting. Yeah.
That's really the only thing I could come up with.
Sarah and I were at this continuing education workshop this past weekend, and one of the guys, the guy who lectured, Dr. Powers, is one of the people who is like he's the guy who literally changed the narrative on what's happening at the knee joint and how important the actions at the hip are. So have you ever heard of people doing VMO exercises?
Mm-hmm.
So the whole idea of VMO exercises were to basically activate a component of your quad to help prevent your tracking issue of your patella. Your patella is your kneecap. And his work really gave a lot of evidence that it's not the patella that's tracking wrong, it's the femur underneath of it. And that's why if I hear a provider giving the recommendation of VMO exercises, I just know that they're only 3 decades, maybe 2 decades behind where the research is at.
That's still 2025. Yeah. I mean,
I think it's fine. It's defensible.
2005. Yeah.
So the idea is that your VMO, which is a muscle on the inside of it's your most medial of all of the quad muscles, that it's supposed to pull and track your knee this direction. It's not going to do that. So it's a mistake. So when we do the testing on Alex, he couldn't lift his leg off the table against resistance. It was...
Which you, like, I remember the last time I did, I could, like, hold your whole body weight.
I couldn't move it, which is what should happen. And then, how much have you been squatting and deadlifting? How much weight?
Like maxes or for reps?
Either one.
Max on my squat recently has been 285.
Yeah.
And I pulled 315 on a deadlift for 3, like, a month ago.
So the way you check glute max strength, it's basically he extends his hip. I try to push it against his forceful hip extension. I should not be able to move that an inch, and he couldn't resist it.
It even popped.
Yeah. Where did it pop at?
In the hip.
Yeah. So, yikes, right? He hasn't been able to walk since the pop happened. That's what you want for the testing. No, and then we had you jump. So we tested the muscles that are functionally going to be responsible for absorbing force, and then, or at least contribute it, and then we had you jump.
And jump felt fine to me.
No pain, right?
Yeah.
Now, one of the things that me and him had gone over before is that he was landing stiff. This time he didn't land stiff, but he landed, his knee shot really far forward, and he was more upright than normal. And then I had him jump again, sticking his butt out, a little bit more trunk lean, and it felt more comfortable.
Yeah, it was definitely softer.
So that's a functional exam, and like I said, that's one of the 4 things: the structural, functional, your treatment response, and what triggers are bothering you. We basically got a lot that you have a tendency to become knee biased with your jumping, which overloads the knee, and then something caused all your glute muscles to shut down.
Hopefully that's just for this morning and not always.
Well, the nice part is it's such an easy thing for us to fix.
Yeah. Well, I'd be curious if I had just done some quick glute activation to see if it
would have come back.
Yeah.
It would have come back, but then it also tells you, though, how often do we do that? How often are people actually doing glute activation, and they're doing it in a way that's actually effective?
I do it every workout, but that's just me.
Yeah, so what do you think happened? Why do you think all of a sudden you're testing weak?
I don't know, 7 a.m. on a Sunday morning.
I don't think that's it.
No?
No.
It's not
think,
fatigue? Reference to the last episode?
Yeah. # fatigue. Well, if we think through it, no, I think it's inhibition. I think there's it could have been that pain event. And what's interesting to me is
But it was both sides.
It was both sides.
Yeah.
So,
which is also not normal for me either. Sometimes I'll have it on one side. Yeah.
So it does kind of speak to it's your ability to produce neural activation. So if we go back to the last episode and we talk about that aspect of fatigue, that I would actually totally agree. So I think it's more of your whole system cannot produce enough neural innervation to your muscles that are there for some reason. So, but what's crazy is, when we were in that course this last weekend, one of the things that he had brought up was the whole idea about, have you ever heard of a homunculus? You heard that term before?
Yeah, very familiar.
Motor homunculus or sensory homunculus?
No.
You've never heard of it?
No.
You ever seen where they show this weird, it looks like a weird body, and the lips are huge, the hands are huge, the body's super small, feet are huge?
Hulkamania?
No, homunculus.
Oh.
You've never seen this? Danny, we're going to have to put that as a photo on here. Okay, so we're at this homunculus photo that should have just shot up right there. So now that is a representation of how the space that's taken up in your primary or sensory cortex, where your body has a really good representation of your hands, for example, your face, your lips, your feet. It doesn't have a good representation of your glutes. actually very small area. It's not
like
that
your
well-defined.
internal perception of these things,
It's-
or like how your body.
It's like a body map. Yeah.
Okay.
Yeah. It's not robust. And if you kind of think of it, we've talked about 2-point discrimination before.
No, we haven't.
2-point discrimination is a test that we can do for sensory, just to basically look at the density of your sensory nerves in an area. So for example, if I had you close your eyes and I tried to figure out how far apart my fingers have to be before you tell me there's 2 fingers versus 1, right? With your hand, it's actually pretty close. It's like that, maybe even a little closer. For your back, it's like that. And that's that density really changes the information that's going up to your brain. And it also represents how robust that distinction is in your homunculus. And so one of the things that his team did is they showed that if you constantly fire, you do really intense activation exercises to the glute muscles, and you do it for a long period of time, you can actually get much better activation. And it's because you're actually building out the homunculus and you're improving the cortical motor tract,
Like reprogramming your nervous system to activate more often.
which is just fascinating stuff. And so they actually showed that and they can do things like fMRI, transcranial magnetic stimulation, these like different tools to basically show that your body's actually doing it better. You can also use things peripherally like EMG to show that you're actually firing the muscle that you want to fire. But what we find in the clinic is that individuals will be doing activation exercises or strengthening exercises for years. And then they come in and they'll say, man, I still test weak. And they'll be confused on it. And it can be confusing, but that means you're making a mistake either in how you're doing the activation exercises, or like my favorite term, you're missing a key sign and maybe a structure that's causing inhibition. Which, so in your standpoint, I would guess it probably came from the pain.
Yeah.
Would be my first thought process.
Even though I'm not in pain right now.
That's kind of the thing is like, that's why I like that I know how you present often is I don't.
You always get me
response.
to tell you like, okay, maybe I'm at a 1, but like, I don't think I'm even at a 1.
Now,
Right.
but that also highlights the aspect that you have an experience like that. It doesn't automatically mean that your system goes back to normal, especially with certain muscles that your body has less robust representation of.
So I need to be thinking about my glutes more often.
I think that glute max and glute med are so critical. And I think that if somebody who's had previous knee issues, my assumption is always to make sure a quad is active, not overactive, but active. But then I go to calf strength, glute med, and glute max are so important. And I don't think that's often dived into enough.
Well represented.
I think that's oftentimes people will say weakness when they mean inhibition, which they're not the same thing. Weakness, in my opinion, is a true measure of what you could perform in an optimal state. And if you still test weak, okay, well, maybe you don't. It's not just the neural drive. It's that you literally don't have the ability to contract the muscle. That can be literally the amount of muscle tissue.
You do not actually have the strength,
have
or you have an atrophied muscle or something to that effect.
But if I can do something in one moment, all of a sudden you test normal, that's inhibition. Which
Your
is a
muscle
very
is turned
definition.
off.
Yeah, and there's something driving it. And that can be from a variety of factors like we talked about last time. There can be an almost infinite amount of reasons, and you want to start to drive down and figure out which thing is actually causing it. Otherwise, every time that you go do an activity, you might be dropping it down. And one of yours, for example, is your knee bias. You've heard the term quad dominant.
Mm-hmm.
Yeah, you're quad dominant.
Yay.
It's really common in athletics. It's partially it's how you get taught, right?
Yeah. Well, and that's interesting because I've just been noticing, like, even with some of my heavy squats, like I rarely feel it in my quads as much anymore.
Where do you feel it?
Like on the inside or the hamstrings. So I don't know if my quads are just oversensitized or desensitized. Yeah, just a weird observation.
Go more into that. Where do you feel it when you squat?
Like either on the inner legs or in the hamstrings even.
Okay, so if you feel it in the hamstrings or your inner thigh, your adductors, that's a sign again that your glute max isn't firing well. Because if you think about it, and this is like when you think about the hip muscles, you always want to think of it as what muscles are involved in every action, because there's going to be some different actions shared actions and then different actions for each muscle. So if you think about the glute maximus, for example, it's a hip extensor. The other hip extensors are going to be your hamstring and your adductor magnus. Those are your 3 primary hip extensors.
Mm-hmm.
Your glute max also externally rotates your hip, and it also abducts your hip. Whereas the hamstring flexes the knee and it adducts the hip, means it brings it in. Same thing, adductor magnus it adducts your hip and it extends the hip. Those are the only actions it has. And so when people get down to the very bottom of their squat, you lose leverage in your glute max. And so have you ever noticed, like, when somebody's down at the very bottom and then they go to push and their knees almost like dive in and they come back out, that moment, that knee valgus or frontal plane motion that's happening, that's typically because your glute max is getting outmaneuvered by the hamstring and your adductor magnus. So if you're somebody who's getting like a whole bunch of pain after you squat in the inner thigh, you have a glute max issue.
I will be refocusing on glute activation in the next month or so.
What's kind of interesting is which one is your issue, right? Was it that jump? So that could have been pain, or is it a patterning issue, which could be the way that you naturally produce the motion? Be kind of cool to figure out. Probably both. Yeah, probably not one. Yeah. Do you often get get pain in the inner thigh?
From what?
From squatting?
Yeah.
Is it a lot like
not pain, but DOMS?
DOMS. Yeah. So your DOMS presents in the hamstring. One moment. Yeah, we're not saying anything crazy here. Okay. Yeah. So you have a, you're breaking down some of the muscle, but it seems that when you're producing maybe some of the biggest load, you're doing it to the muscle you don't even want to target.
Yeah. Interesting.
Yeah.
All right. I'll need to try and refocus on that and see what I can do.
What's interesting, because I tested you literally a month ago and it was normal.
Yeah. I don't feel like anything really has changed, but obviously something has.
But I think it does speak to the idea, though, that this is one of my biggest ideas or thoughts around long-term health. It's the idea that once you're showing a predisposition to certain things, for example, dominating with your adductors, dominating with your hamstrings, and you've had a history of knee pain, I think about how do you do long-term management for that? Because long-term management for you then, in my book, would mean periodically checking those things for you. Because if we don't check those, it's hidden until you actually have a pain event. And that pain event, hopefully, it's nothing big. But if you constantly are doing that, and we know you're predisposed to minimize it just from who you are, which I actually I totally understand. But how do we keep you healthy? Like, how do we keep your... I mean, it's actually a real question. Like, how would you want to be supported in that?
Well, that's what I'm saying. Like, I'm not feeling anything. I had the one pain thing. And like, one of the questions is like, okay, if I went and got an MRI right now, what is the likelihood that some sort of pathology is on there?
Pretty high.
Right?
Yeah. So let's just say
I have no pain.
Symptoms.
I'm able to perform. I was obviously able to jump just now.
What would you think if they came back, which the most common one, you have some level of damage to maybe the anterior horn, the front part of your meniscus.
Yeah.
What would you do?
I don't think anything would change.
So I think some people's
I'm sure for some people, you get a diagnosis and it's like, this is the end of the world. I'm never jumping again. Kind of like the intro said. But in all reality, especially from me working with you for so long, I've had a torn labrum in my shoulder. I've had a torn calf. I've had all these different either tendon or muscle or whatever tears, and I've been able to rehab my way back to probably not prior performance, but at least pretty darn close.
I think that's the part that I find the most interesting is that I definitely had a stronger, I don't have this opinion anymore, but I used to really get nervous when people would get MRIs, they'd get images, x-rays of their knees, because I don't think there's a strong relationship to disability and pain. So say I have something where I can't see it in the exam. Say your exam's negative. My brain immediately goes to, and the person has pain, immediately goes to, okay, you're probably not functionally managing force well through your knee, or you have some functional thing that's driving this symptom. You're most likely dealing with like a patellar tendinopathy or overstrain to some tissue that absolutely does not need surgery. But then I've had people come back with a negative MRI, but then I've had people come back with your bone on bone, and the exam doesn't support that, for example. And what I found fascinating is I can't predict how the person's going to respond to that but it's not a small amount of people who've ended up doing surgery for things that did not have a defensible reason for surgery.
Well, and even like thinking about how a doctor is reading an image. I mean, I go back to when I broke my wrist. I had broken it, I think 4 days before, and the doctor was adamant that this was an old break. It's like, no, I can tell you I had a significant acute event where I broke my wrist 4 days ago. And he's like, no, this break has been here for weeks. It's like, telling you that's not the case, but you are adamant that I've had a broken wrist for...
What did you do in that situation?
No, I was like, here's when I got the image 4 days ago at an urgent care. I can and he's like, oh, okay, well, I guess you're right. Like, no, I know I'm right. How are you so wrong? Yeah.
You crushed my opinion on what you know based off of that, right?
Yeah, and it was kind of the first time that I really doubted a medical professional.
Really?
Yeah, and it was just an interesting case, but to the same effect where, you can see something on an image and it can be wildly different what's subjectively happening with your either pain perception or in your body altogether.
I remember my experience happened with my leg, obviously decades ago when I hurt myself, and the aggressive stretching of something that turned out to be a nerve. I think that's one of them where I didn't have the terms for it at the time, and then really come into it because I still have this nerve injury that if I stretch it now and I clearly know what I'm doing, I can cause neuropathic pain that lasts for days. So it's just funny that was the main treatment I had for my issue. So it is interesting where you have, that's once again, we were kind of talking about this last time, where somebody will put forth a diagnosis or a management strategy that they can't be wrong with. You feel tight, which is the tightness I was experiencing was because of a neural pathology, and their treatment couldn't be wrong because every time I stretched it, it made me feel a little less tight for a second, but then it came back raging. They couldn't ever be wrong. You have to stretch tightness, So in that type of situation, it is crazy. That's yeah. And I don't know. It's hard when I don't know how, I don't want to go after somebody when I don't know.
I didn't name any names.
Yeah. Well, so I guess to kind of go back to what we're talking about though, the issue that I'm running into often now is individuals will have treatments that are done that make the symptoms better in the moment, but then worsen the long-term outcomes. And that's how I view meniscectomies. Sometimes they are necessary. Say somebody gets like a locking in their knee, but now we know your area that knee joint's got to absorb force through is now smaller and less congruent, which means you're putting yourself down a pathway of the joint the joint compressive force is always being higher, up to 300% higher than what they were before. And how do you manage those people? And how do you get somebody to want to continue doing management when for maybe 5 to 6 years they're going to feel good? Like how often would you want to come back in and have it checked out to prevent long-term damage when the times that you come in it's not going to seem that you need medical help?
Well, and I mean, I'd imagine with a meniscus surgery, you can either go through, who knows, a year of rehab, or you can get this surgery and maybe you'll feel better in 6 weeks, 8 weeks.
You feel better much faster.
Right.
So say, for example, you have a damage like the meniscus is actually damaged. You will feel better right after the surgery. It's one of them that's pretty obvious.
But the long term
yes.
Of both scenarios, right? The long term of having a meniscus surgery is probably less good or less beneficial.
Anytime you do surgery into the knee, your long-term outcome gets worse, in my opinion. Yeah.
Or you do whatever, call it 8 months or a year of rehab, get yourself feeling just as good. It's going to take a lot longer, but then your long-term outcome is obviously going to be better because you've strengthened all the things and kind of naturally fixed your problem.
I'll put a caveat on that one. If you make sure that you manage those 4 variables for knee health, for example, complete knee extension, knee flexion, no joint swelling, and your quad stays strong. And then you throw on top of that, you use a hip bias and your glute max and glute med and calf are strong. So I always think the bottom 4 are the most important initially. You have to make sure your knee is completely extended. You get all your flexion back. It's just a sign of your capsule and your joint being healthy. You don't have any swelling inside your knee joint because immediately that you actually just had that. I mean, was that 3 or 4 months ago?
Yeah.
And so that happens often. People will have these micro events that they don't even realize that they jammed their knee and it's actually swollen. And that is extremely common. It's just a sign of how incongruent the knee is and how easy it is to overload it.
And that was, I mean, slightly painful.
Yeah.
You know, on the pain scale, you couldn't get me to admit to anything. But
it was kind of wild though,
Yeah.
right? Seeing the swelling for the first time like
Right.
that. And then long term, your quad has to be very strong but not overactive, which is its own issue, because most people who are athletic, they go down a quad dominant pattern. So we nail those 4. So if you had a meniscectomy or if you have knee pain, those 4 things need to be managed immediately. And then you think long term about, okay, how are these things that also reduce force going through the knee joint? Hip dominant pattern, meaning that when you absorb force, you're getting more through your hip and glute max than through your knee joint. You have good glute med and you have good glute max strength. You do all those things together, and I think that your outcome will be much better. But the crazy part is you can be doing things that are bad for the knee for a really long period of time before you actually get to the point where you throw in the towel. And I find it difficult. It's a surveillance system, an injury surveillance system or management system. I'm surprised we don't have more of those. Like we have it for exercise, for example. We have it now for osteoporosis. But the biggest thing that gets people to quit being physically active, you're 7 times more likely to quit from our data if you have injury during your first 6 months. So if you have an increase in pain, you're 7 times more likely to quit. And so most of the times where people want to become physically active, it's not that they don't know how to exercise. That's the issue. It's that they don't know how to show up. 33 times more likely to quit if you score high on our accountability construct, which just means you're likely to quit if somebody's not holding your hand or you don't know how to schedule yourself type of thing, or if you have a new injury. But how often are exercise programs actually focused on the biggest issue that's going to cause somebody to stop?
which is just the rehab portion of it.
Yeah, I think that's wild. But then it's also, so if somebody who wants to not have a total knee, you have these like 6 things or 7 things that you should be looking at. But the number one thing that people use to tell them that they're going to get a total knee is imaging.
Yeah.
I just find that wild.
You got to think most of the time when you're going through imaging, especially if it's for a knee, you're going to a surgeon. The surgeon's the one ordering the imaging. How does a surgeon get paid? By doing surgery.
Yeah.
And so, I mean, I had the experience with my shoulder where it was like, do 4 weeks of physical therapy. And if that doesn't fix it, we'll do surgery. And then, coming and speaking with you is like, well, you're probably going to need 8 months of physical therapy, but you won't need surgery. And obviously I went that route and had a better outcome. And I've known people that have had that surgery before and have never been able to hit a volleyball again.
Really?
And it's scary.
That's not fun.
Or at least not being able to do it without pain.
Yeah, one of them that I've had a lot of experience with. It's been interesting that I would have said when I first started. I always assumed if you tear your ACL, you should absolutely get it repaired. I don't feel that way anymore. That's one that's been a big change in my thought process, partially because of how many not of the like bad outcomes I've seen now with ACL repairs. But it is interesting when you talk about surgery, and I'm not even saying I don't know if the idea is their business model is what's driving it. I think a lot of these surgeons have more work than they could ever service. I don't know if it's, hey, I'm trying to get a new BMW.
Well, and I'm also not saying don't see a medical professional or don't trust them. I feel like we've kind of gone a little bit too far down that route today. But
yeah, well, no, I mean, I think I've worked with a lot of surgeons, and I think they have a different bias, a different lens, and I think it's a valuable lens. I think it's understanding what bias you want to have at different moments in your healthcare journey. I don't think you want the surgical bias to be your primary bias at any point. I think those guys get too much on their shoulders. I don't think that they have, like, if I had a perfect situation, I would love it if the surgeon only got fed cases that were always cleared for them ahead of time. They failed therapeutic, they failed treatment. They have all these people who've done workups for them, and now these guys carry out the surgeries. Yeah. And then I also think that they're not set up well to carry out the rehab, but they have strong opinions on rehab, but they don't carry the rehabs out. So I don't think their opinions on those aspects of it.
Well, even those prescriptions I feel like are way too small.
Yeah.
I think back to my wrist
Long
and it was
term.
like, you'll do 4 weeks of physical therapy after you get your cast off. And it took us 6 months to get back to a a functional area for that one. And I'd assume the same for meniscus.
Yeah.
Like you were saying, you don't even need rehab after this surgery. Like, what are you talking about?
We hear that all the time. And it's my idea on that one is I don't disagree that they're going to be more functionally normal. You're now assuming that their walking went back to normal.
Well, and I think that's the assumption is the surgeon is looking for you to be able to walk for the rest of your life.
Yes.
Which is fine, but there are people that want to go and jump 40 inches or go and run marathons or any of these other athletic endeavors, and that's not the outcome that's in mind.
But even when we talk about walking, and this is to me is like thinking about the frame of how we think about it different. Your surgeon's not looking at how you walk. When you walk, there's seven different points in gaze. You have initial contact, load and response, mid stance, terminal stance, pre-swing, mid-swing, and terminal swing. I might have missed initial swing. But anyway, so you go through all of those, and there's points as you go through it that things need to be happening. The most obvious one, when your heel hits the ground, your knee needs to be completely straight at initial contact. When your foot goes flat, that's called loading response. Your knee has to flex to about 20 degrees. Majority of people who come in who have knee pain, their heel hits the ground. They may or may not be able to get full extension. And if they don't have full extension, that means they're missing extension, which is one of the number one variables you have to get back. And then if you don't trust your quad, you actually rapidly extend your knee and your ankle goes down flat. So you literally jam your knee.
Every time.
Every single time
Thousands
you
of
take.
times per day.
Every day, right?
Yeah.
And the assumption that just goes back to normal, that's not true. Just because you take the pain generator away doesn't mean that the quad came back to normal, doesn't mean you regained full knee extension. It also doesn't mean that you normalized the pattern. You can't assume that the pattern normalized. That's just from the basic standpoint, and those people may be pain-free. They may have no functional limitations that you can catch from a functional outcome tool. Like for example, you could take them on a 6-minute walk test and it tests normal. Their gait speed could be normal, but they have this motor pattern that's completely off. That's a huge issue.
And long term could cause some problems.
Yes. Yeah. Right?
Right. Going back to my little knee issue, I just kind of remembered that like I immediately went and did a wall sit. Like I just have been, isometrics are my like little miracle cure for any of my knee things. And that I think that is probably why my pain went down immediately. But just kind of to close out, say you've had your MRI report or you've got a little knee issue going on, like what are your kind of go-tos to either start rehab or kind of start yourself on a path to feeling better or having less anxiety over it?
Well, the very first thing is get a very clean exam. So say if it's transient and it happened one time and you've never had this issue before, I'm not stressing about that. Well, that's not what I'm saying. But I do think that if you have something that's recurring, it happens over and over again with your knee, you want to figure out what is happening. And like I said, I think there's the base 4. You always need to make sure are clean. So you have full knee extension, full knee flexion, strong quad, no joint swelling. And then after that, say we get all that feeling good. You have a normal gait. I think I said 7 phases, but you have, like I went through before, it's actually 8. But your normal hip dominant pattern, make sure that that's normal. And then everything that absorbs force in your lower extremity should be normal. If you hit those 2 levels and then you have a really clean key sign that tells you if something's feeling wrong and you have a really clean home plan that makes stuff feel better that we feel is abnormal, you're in a really safe place. And then I think that it should be monitored. And that's how we talk about phase 4 is maintenance, monitoring, and performance. I don't think that we have a good system in America, and I would even say anywhere, that manages where people do not perceive pain but have something that's brewing in the background that's going to cause an issue in the future. And I don't think we have a good system for it. And that's one of the reasons why the way we operate, we actually do actively try to keep people in systems that keep them from regressing without you realizing it. That's why the body inventory is so useful, because the most likely injury you're going to have in the future is one you've already had. And then most often you probably didn't completely rehab it. You never close the rehab gap. So you always have this gap between your physical capacity and your tissue capacity. And then not only on top of that, to make it even go farther, do you have enough energy? Is your energy capacity low so that you're constantly pulling from your tissue capacity? So we have these situations where we inadvertently make ourselves more fragile in the future, where it'd be much easier just to try to build a really strong foundation from the start.
And that's why the Smith Performance Center system works.
That's what we work, baby.
Alrighty. Well, your knee isn't broken just because a piece of paper says it has a little wear and tear. Stop panicking about the structural snapshot and start focusing on making the surrounding tissue strong enough to do the heavy lifting. And yeah, don't go having unnecessary knee surgery without coming and talking to Craig and his team first.
Yeah, and if you do have surgery and you want us to check it out, let us know.
Yeah.
Yeah. So we are a non-judgment zone.
Judgment-free clinic.
We are a judgment-free clinic. So we're fine if you want to have surgery. It's more, we'll give you our perspective on it, but yeah, we're good for either. If you are enjoying this podcast and finding the information useful, please consider supporting us by following the show on Spotify, Apple Podcasts, or wherever you listen.
By subscribing, you help ensure we can continue bringing you this high-level training and rehab science every single week. Leaving us a 5-star review on those platforms is also one of the absolute best, zero-cost ways to support our mission and help grow this community. Our podcast is proudly sponsored and brought to you by Smith Performance Center. If you are an active adult looking to bridge the gap between rehab and elite performance, or if you want to optimize your health from every angle, go to smithperformancecenter.com. They offer elite physical therapy, strength and sports training, and dedicated nutrition coaching to help you build a resilient body that handles the activities you love without breaking down.
If you want to connect with us, see our training clips, or watch the full video versions of these episodes, follow us on Instagram at Spiker Kiker, Craig Smith PT, and Past Your Prime Podcast. And subscribe to the Past Your Prime Podcast on YouTube.
Thanks for tuning in, and remember, you're not past your prime, you're just getting started.
PYP, baby.
Peace. And I burnt my tongue eating pizza yesterday. Okay.
Don't do that.
1, 2, 3.